Well, good afternoon, everybody. It's a real pleasure to speak at the Society of Tissue Viability. My other role, because I like to speak up for social care, is I'm the National Institute of Health and Care Research's North West Regional Research Design Network residential settings lead. I've recently got into, well, for the last 12 years I've been doing lots of research in regards to tissue viability and wound care in the social care sector, and I'd always want to highlight that work because, for paritative esteem, we are health and social care. So on this slide here, you'll see that this is us celebrating and introducing to you this afternoon our third edition of the seating guidelines. And whilst I might be presenting, there has been an absolute wonderful team who are all named on this slide who have helped in the authoring, the development, the writing, the reviewing of the guidelines, and many are in the audience today. So before I go into the guidelines, I just want to talk about the objectives of this session. So I'm hoping that when you've listened to me babble on for about 30 minutes, you'll be able to highlight this publication of these new revisions to the seating guidelines. You'll be able to explain the process in which they were developed, because we want to be rigorous and robust. And also to think about the new additions since our publication back in 2018, of which obviously we were very proud of. So the good thing is, woohoo! Yeah, I like to wake you up, sorry. Yeah? It's like birthing a baby, writing national guidelines. It's something to celebrate. And as you can see, the stalk on your right-hand side, we've given birth to this project. Yeah, we've given birth to these new guidelines. They're our third edition, and lots happened since 2018. We've had the COVID-19, sorry, I'm trying to whisper that. We've had changes to our socio-political landscape. Think of how many prime ministers we've had since 2018, some who've probably decimated our economy. And also our health and social care landscape has significantly changed. And we can only hear of the announcements by the recent government to NHS England. But things to celebrate, let's not think negatively. What a fabulous team of authors I had the privilege to work with over this period of time. Some who were researchers, some who were academics, occupational therapists, trustees of the society, patient safety leads, physios, tissue viability matrons, and lots of nurses, registered nurses. And you might think, well, why have you done that? Why have you had this team? It's the Tissue Viability Society. Well, I love the term, we do not sit in splendid isolation. When we deliver care to prevent and manage pressure ulcers, we do it as part of a multidisciplinary or an interprofessional approach. And that is also in collaboration with our service users and their significant others and carers. So it's really important that we celebrate that. We also have adapted the title, and we've put on, you can see on the slide, what does it mean for us all? Because this was really important when we had our conversations, developing the guidelines. They're for everyone. Everybody who's involved in reducing the burden of pressure ulceration, especially for the people who sit for long periods of time. Their carers, their significant others, their family, our health and social care professionals, people who deliver education and training, our private, our independent, our voluntary organisations, and our industry partners. So how did we produce them? So it's really important, if we're going to produce guidelines that are going to be implemented into practice, that we follow a rigorous and robust process, and that it has a systematic process. So following the NICE guidance in the development of guidelines, we wanted to ensure why we needed them, areas we will or won't cover, our draft scope about sense checking, what should be in there and shouldn't, a review of the evidence, and then developing our objectives. And as you can see on the screen, it was to update our 2018 version, and then report on what the current evidence base has been saying since that time across health and social care. and also to re-examine the devices that are available, the interventions, the approaches, and the evidence base of that for adults who sit for long periods of time. And I keep going back to that because this is about adults who sit for long periods. So how do we do that? So in order to conduct a really thorough review, it's important to ask a research question and then set some research objectives. And you can see we ask the question, so what do we already know about the prevention and management of pressure ulcers in adults who remain seated for long periods of time? And because I'm a researcher, and I didn't used to be, I started my nursing career as an auxiliary nurse on nights at Blackburn Royal Infirmary, and then have progressed my way up. So if you think you've got research with a big R and a little r, I might be doing big R, you may be doing lots of R's, but we can all do research. So we use something called the PCC framework. So we need to understand who's our population that we're going to study and investigate the literature. So this is adults who remain seated for long periods. And then the C is for concepts. So what kind of interventions did we need to explore in the prevention and management of pressure ulcers? So we needed to look at things like, what's the latest evidence base on seated position? How should a seating assessment be performed? How should we, or what is the available evidence on pressure relieving or redistributing cushions and chairs? What's the use of tilt and recline? What use do we have for repositioning schedules? And also, because it's for everybody, the self-management. What activities and interventions can people themselves implement in their own care? And then the context is obviously the prevention and management of pressure ulcers. This PCC helped us develop our keywords in order to do a comprehensive search of the literature. And that was conducted with studies limited to 2011 to 2024. So you can replicate our work to see if we were robust in our process. Unfortunately, we could only look at studies written in the English language, and we know that that limits sometimes the use of evidence-based practice, but this was a document, a national document for the Society for England. We searched different databases, and we also did something called grey literature and hand searching. Really important to make sure that we encompassed included work that may be in organisations who've not published it in a peer-reviewed journal. We even looked at EPUAP and the European Wound Management Association. And then we also, because we're very inclusive, we engaged in other activities. And this was to garner feedback, because there's nothing like PPIE and stakeholder involvement to ensure guidelines are robust. So we went out to speak to our colleagues in health and social care, industry, and also the individuals who sit for long periods of time. And these activities, as you can see on your slide in front of you, included a listening session with occupational therapists. These were from Lancashire County Council, as one of our team of authors actually worked in that local authority. This was the delivery of 3 focus groups to look at the priorities and features of chairs and cushions for people who we need to prevent or manage pressure ulcers. And then we conducted an anonymous survey at the European Wound Management Association and the Society of Tissue Viability conferences, again to garner that information on what are your priorities of people working in the field for choosing the right piece of seating or cushion for someone who's at risk. And we'd like to thank every 181 people who took part in those activities. And the reason that we did this is we want to ensure that everybody has access to evidence-based health information. Yeah, it's really important regarding the prevention and management of pressure ulcers. So we wanted to ensure that not only we garnered stakeholders, but we also went out to people, individuals who were affected. So we actually have written the new guidelines in plain English, And these were peer-reviewed by service users, and we'd like to pay particular thanks to Dr. Stephen Duckworth for that. Because if we look at the literature, especially if we think about NIHR and NICE, when things are written in plain English or in the language that somebody understands, it improves our communication with them, it builds trust, it also enhances our engagement in empowering people to take ownership of their health and well-being, and then also it enables better understanding. So individuals will then understand the diagnosis, the treatment and the interventions when it comes to pressure ulcer care. So writing the guidelines. Well, it was really important when we're writing the guidelines to ensure they were accessible to all. We also thought about the term pressure ulcer with the light of changes, should we move to pressure injury? But we said no, we'd stick with pressure ulceration. But we know and we make reference that some people, especially people in our communities, refer them still as bed sores, or even some people who still refer to them as decubitus ulcers. And we also use the term throughout as people. And this is for service users, patients and residents. And this is because as a group we started to recognise that for many years social care has not had the same parity of esteem as healthcare, especially in the literature and also in research. Yet we now know the social care workforce and bed occupancy in organisations is actually larger than the NHS. So not everybody who receives pressure ulcer prevention and management is a patient, and most of these are served in the community. So we wanted to reflect that. So our process for writing the guidelines was based on our knowledge, our skills, our expertise and our interests. And within the process of writing and revising the guidelines, we built in regular meetings and peer review. And we'd like to say thank you to two particular trustees, Jo and Innes, for being our final critical peer reviewers, for their invaluable comments and feedback. This is really important as researchers because it ensures our validity, our quality and the relevance of our guidelines before they become published. And our expert reviewers were there to determine the accuracy, the completeness and the impact of these guidelines. So you're all thinking, oh, a researcher. She's babbling on about the process of research. Get to the point, Melanie. So what have we added? What's new in these guidelines? Yeah, so the exciting bits. So the first thing I want to say is that at the heart of these guidelines is they're for everyone. This is so important. And that's, as a nurse, and thinking of person-centred care, it's the people of whom we serve are at the heart of everything. The second thing is in the background section. So after peer review from our service users, they said, we'd like to know more in a really understandable way what pressure, shear and friction mean, so that we can understand how serious this complication is of being seated for too long. And also we can then help prevent ourselves from developing pressure ulcers or helping you, health and social care staff, for managing them. So again, really, really important about promoting further information. We also looked at the recent data from a European study and a UK study in the management of high-risk people when they're seated in comparison to those who are on bed rest. And what we found in the data was less than 50% of at-risk people receive a specialist chair or cushion. That's phenomenal. And I know this is Europe, not just UK, but that is phenomenal. And that includes a piece of a chair or a seat or a cushion. When they look through and ask questions about repositioning, when someone's seated, it's performed less and also more irregular than those who are in bed. And the proportion of patients or people who have care plans to prevent or manage pressure ulcers in seating, again, is less. So we need to address this disparity. It highlights that we need to become more aware that we need action to address the issue for those who sit for long periods of time. We have also included staging and the images of darker skin tones. We recognise we live in a multicultural society and our guidelines should reflect this. And then when we come to the risk factor section, again from feedback from service users, they said we need to hear about these risk assessment tools. Don't just say these are our risk factors, but tell us about what tools you use as practitioners to assess that risk. So we understand, again, what is being used and why you're using it and how it helps us and you. And also about the optimal seated position. We've changed some of the terminology to reflect more current practice because our AHP colleagues from occupational therapy and physio, who usually will conduct seating assessments and also then provide chairs or cushions, we need to blur our learning. We need to think about when they're not there, is there something that we know or can understand and support that? Because we know that good seating isn't just about pressure ulcer prevention and management, it's about function, occupation, activities of daily living, good posture, so really important. Other additions, you'll be pleased to hear, include interventions that someone should expect after a seating assessment. And we really wanted to look at the issue of equipment abandonment. For those who work in the community in particular, you may go in and put some equipment in and then find it in the bathroom or in the cupboard or under the stairs. Yeah, this resonates with some of you in the room. And therefore, it's important that we think of the literature and the evidence base about working with people about accepting and using seating equipment. There's a trade-off, isn't there, between what we think as health and social care professionals and the ideal of what the end user requires. So we need to think about their individual lifestyle, their capabilities, and their personal preference. You know, it resonated with me when I did a study on some chairs when we put them in one home and the participant said, I want you to take that out. I don't live in a nursing home, I live in my own home. It's not relevant for me. It didn't match the colour of her furniture. She wanted to hide how it looked. And I can understand that, yeah? That's their reaction. So we need to think about involving negotiation, and we know from recent research by Howard and colleagues who explored themes why people abandon equipment. The first one is the design and function of it, that really most of the time it lacks end user involvement. So people don't want to use it because it's not easy to use, it's too cumbersome, or it's not for use in certain environments. Or they've never been given information about that piece of equipment. So therefore, why should I use it? I don't know how to use it. Or when you've left them with the piece of equipment, they forget. Also that people want to be involved in choosing their cushions and their chairs. They want to be part of that process because it could be that psychological barriers are then created. So the equipment then becomes too awkward to use. It annoys them, or it's not appropriate for them. And it's really also engaging the family networks and support networks, because Howard and colleagues found that if the family or the friends didn't like the equipment, the chair or the cushion, neither did the end user, which is really interesting. The dynamic still of peer influence. And then just general stigma from society about using what we call really assistive technology. This is assistive equipment. We also found from our surveys and our focus groups that the features and priorities have not changed for service users, but they have changed for health and social care professionals. So service users or individuals who sit for long periods want to be comfortable on a pressure redistributing cushion or piece of seating or a chair. They want it to look nice. They talk about the aesthetics. They want to be able to carry out activities of daily living and be able to function when using the chair. And they also want it at a reasonable cost if they have to pay for it. Whereas us as health and social care professionals say our priorities, we want the chair or the cushion to provide good postural support and also function for the person. Then it's comfortable, then it's easy to use for transfers and also to carry with them if they're moving it around. But then our professional opinion should come next. So this demonstrates this need for consideration of end users and their priorities, that they differ to ours. We want to prevent equipment abandonment. It costs us a lot of money in resources each year. We've also included a new cushion. There's a spacer fabric cushion that's been developed, which is a knitted fabric consisting of 2 separate knitted surfaces joined together back to back that's now being utilised. And we also wanted to include what to consider when purchasing or renewing cushions and seating, because service users, individuals who sit for long periods of time, want to know this. And we know this is a holistic approach. It's not just oh, you just need this cushion. It requires a seating assessment. We need to think about how is seating or the cushion going to be purchased? Is it one off the shelf, directly purchased, or is it something that needs to be bespoke and made to fit the person? Does it have to include postural support or not? And what interventions are required when the person is actually sat on the cushion or sat on the chair or the seat? And what the priorities, as I said before, but for both end user and the professionals. Who's going to supply it, the stages involved, the brand, the size, the range and instructions. So it demonstrates really the significance of it's not just a cushion, it's not just a chair, it's a specific piece of equipment that is needed for many functions, not just pressure ulcer prevention and management. And then we've also, with the self-help suggestions, kept in the addition of a small s to the asking model, because as we say, it's for everybody. This heightens the vulnerability when somebody's sick to increasing the risk of pressure ulceration formation. And then two of the final things we've included are the standards of how to test cushions and seating from industry standards, using technology such as pressure mapping, and then the self-checks that we can do and also the person can conduct, such as checking for bottoming out, water and fluid penetration, breakages and tears. And the red flag there is to highlight and address areas of practice that we think are really important. So the reactive hyperemia and skin tone, changing from footstools to more appropriate leg elevation equipment, recline and tilt function of chairs, cushion selection, and the use of standing frames and wheelchair standing devices. So, nearly there. So finally, we'd like to welcome you to our new Society of Tissue Viability Guidelines. They are now available on the website, and if you go to the Society's stand, they've got the QR code waiting for you. But fortunately, you've got our at a glance leaflet that is meant for people as a quick leaflet to give to support what you're doing. I'd like to thank you for listening. We hope you enjoy reading and using these guidelines. Thank you very much.